Good evening. I'm Bertha Cooper, a member of the League of Women Voters and your moderator for this evening. The League welcomes you to the second of 4 important forums on the urgent need for broad health care reform. We are pleased to share the sponsorship of these forums with Olympic Medical Center, and we are grateful to Peninsula College for allowing us the use of this little theater, which is a wonderful venue for our forums. When the League Committee on Access to Health Care met back in January to plan these forums, we decided that we needed to devote an entire forum to the ethical and moral questions surrounding the healthcare debate. This is the debate about the intrinsic value of healthcare in our society. The opposing ends of the debate are reflected in the question, is healthcare a privilege to be earned or a right regardless of individual responsibility? In our age of sound bites and campaign slogans, tweeters, and minute-by-minute communication, it is hard to get below the bites, slogans, and tweeters to have dialogue. Our intent tonight is to get below those slogans and bring these questions into view and provide the opportunity for dialogue and thought. Before we start the program, I must first tell you about the League of Women Voters. The League of Women Voters is a national organization of which the Clallam County is a branch. We are a nonpartisan, nonprofit organization. Our focus is on issues which affect all people regardless of political persuasion. Issues such as water, environment, education, and healthcare. We also present election forums with political debate between candidates and about ballot initiatives so that people can be informed voters. Start looking for those announcements following the primaries. Conducting forums like this one is one of the ways the League encourages informed and active participation in government. Your participation tonight helps us carry out that mission. We thank all of you for coming and are glad to see so many of you here. I hope you picked up a program on the way to your seat and this bright yellow glossary of terms and questions and a small card that you can use to formulate your question for our open mic later in the program. We want you to know that we are recording the program portion for future use in our community. We will not be recording the open mic part of it. Our forum rules are simple. We ask you to turn off all electronic devices that could interrupt the forum. We time our speakers and give them the courtesy of alerting them when they are close to the end of their time. The forum will end at 9 o'clock. At completion of the program and panel discussion, we will have questions at an open mic as time permits. There are no long breaks planned, so feel free to get up, stretch, or leave the room if you need to at any time. The League takes no position on the statements made by the speakers other than we think it's important to listen to their message and decide the importance to you. However, in the interest of disclosure, we want you to know that the leagues have developed position statements in some areas and not in others. In the case of healthcare, the national, state, and county leagues have a position on healthcare which is in support of universal access to healthcare. And the county chapter also includes support of single payer. The League websites have been included in your program if you wish to read the position statements. But we are not here tonight or during the remaining 2 forums to discuss these positions. We will discuss alternatives to our current system in the final forum, and then we will cover an array of possibilities. Rather, our intent is to give you information to inform and to involve you in becoming a voice in the need for broad healthcare reform. That voice will be yours in whatever your point of view becomes. We believe that our policymakers will respond to the voices that expect them to do the hard work of reform, and soon. Finally, and this is a commercial, if you like programs such as this, please donate to help us provide them. Donations will go to paying expenses to the speakers we have invited into our community. Look for the big donation jar as you leave. As I mentioned, this is the second in a series of forums. I will summarize the points from our first forum in a moment. First, the remaining forums. The third forum presents the complexity of healthcare in our country as a market. There are multiple and varied incentives with the existing structure that are often at odds with each other. This forum is being scheduled for late September or early September. The fourth and final forum will present alternatives and solutions to our current system. Now to the program. Our first forum, held in May, made the case that there was urgency to reform healthcare in our country, and I will briefly recap its main points to put our discussion tonight in the context of the urgency of healthcare reform. The single greatest driver for needed reform is the unsustainable cost that consistently escalates at a rate higher than other segments of our economy. The cost of health insurance or services is a burden to individuals, businesses, especially small businesses, competition, and the economy of our country as a whole. We heard about working individuals who could not afford health insurance and would have gone without care were it not for the care they received through Dungeness Valley Health and Wellness Clinic, supported by donations of time, services, and money. We heard about people with costly insurance plans and monthly premiums or high deductibles who forego care because they can't afford the deductible. Eric Lewis, the CEO of Olympic Medical Center, told us that the trend, with or without the Affordable Care Act, is declining reimbursement and increasing cost. He highlighted the dilemma that a local rural hospital and providers face when the only solution applied is to reduce payment to providers. He said it's especially true of OMC that has nearly 80% of its reimbursement from Medicare and Medicaid. Dr. Frederick Chin, an associate professor at the University of Washington School of Medicine, finished by giving us the economic data and health outcome data. He helped us understand that our cost per capita over $8,000 is higher than any other country by 50% more than the next highest country. He helped us understand that health outcomes are sinking in comparison to other countries, mostly due to variability of access. Our life expectancy at birth is going down, and we rank low in comparison to other developed countries. He helped us understand that the system incentivizes doctors to become highly paid specialists instead of primary care physicians, and that the system incentivizes testing. Most of the speakers emphasized the imperative to reform the structural incentives of our healthcare system that drive up the cost, such as fee-for-service medicine, which encourages volume in doctor's visits, volume in testing, and volume in other services, and not systematic disease management and prevention. Tonight we focus on what we are calling the ethical moral questions that may well be the foundation for the solutions to this important issue. Our first speaker is Dr. Sarah Shannon. Dr. Shannon has an important role tonight. She will be helping us present and discuss these important questions, something she is well qualified to do. Dr. Shannon is an associate professor of biobehavioral nursing and health systems, School of Nursing, University of Washington. She is an adjunct bioethics and medical history for the School of Medicine, the University of Washington. She is a clinical ethicist, University of Washington Medical Center in Seattle. Dr. Shannon's area of expertise is healthcare ethics and communication among the healthcare team and between the team and the patient and the family. In particular, her work is focused on end-of-life decision-making, disclosure of medical errors, entrenched conflict, and interprofessional education. Dr. Shannon is a longtime member of several local hospital committees, ethics committees, and a frequent local and national speaker on issues on bioethics. She is currently on the executive board for the American Society of Bioethics and Humanities. She has also served as a consultant to Olympic Medical Center's ethics committees. Please welcome Sarah.
Are you able to hear me? Well, it's my pleasure to have the chance to talk with you about some of the ethics foundation to healthcare. And I thought I would start with a source that I think you will all be able to relate to. You guys remember this cartoon? Calvin and Hobbes are playing. Calvin says, I don't believe in ethics anymore. As far as I'm concerned, the ends justify the means. Get what you can while the getting's good. That's what I say. Might makes right. The winners write the history books. It's a dog-eat-dog world, so I'll do whatever I have to and let others argue about whether it's right or not. And Hobbes gives him a little push and he says, hey, why'd you do that? You were in my way. Now you're not. The ends justify the means. I didn't mean for everyone, you dolt. Just me. Well, there we are. Trying to figure out what is the ethical basis with which we are going to think about healthcare financing in the U.S. And one of the things that's difficult about talking about healthcare reform is that, first of all, it can just be plain risky. Have you noticed that when you're trying to have a discussion? And it can also be somewhat frustrating. You can feel a little talked at in these conversations. So it can also become very politicized, almost immediately. And my hope is that we can stay away from the political to really think about the ethical tonight. But, whoops, I went back before you had a chance. In this cartoon, we have the donkey who says, I'm a poor Democrat who can't get a backbone. We have the elephant who says, who cares? He's heartless. And we have the town hall protester who says, socialism, fascism, death panels. And these are the pre-existing conditions that we're going into healthcare reform. So if we can tonight, what I'd like to do is just set aside the politics and to think about what are the core ethics, values, principles, and the morals that we need to think about in order to make good political decisions. So talking about that brings us to justice in healthcare financing. There's some useful assumptions for us to start with. First of all, reasonable people disagree, right? Healthcare financing is a genuine, difficult, and universal problem. There is no country that has it perfect. If there was, we all would have figured it out and would be doing what they're doing. But this is a difficult problem. Just as Bertha said, we have to have a change to the status quo. When they do the surveys right now, even though there is somewhat of a majority that are not sure they like the Affordable Health Care Act, there is 3/4 of Americans that say we cannot stick with the status quo. So change is inevitable. Another assumption that may be helpful is that the U.S. may end up with a hybrid, a new model. Healthcare has changed dramatically, and the financing for healthcare has changed dramatically in the last decade. Even countries that have had universal healthcare systems or single-payer systems are right now looking at making some changes. So we may want to think about that we're not adopting a system that exists, but creating a hybrid or a new one. And finally, justice requires that we think about what do people deserve and what do we have a right to. we're really going to tackle tonight? Those are big questions. And what I'd like to do is to think about those within a couple of concepts that I have found helpful as I've tried to grapple through this literature. I have about 20 minutes to cover, 20 years, but I'll do it. So Rawls has talked about justice is one of the first things we have to do to truly establish our basic social institutions, to make a decision about the foundational structure of society. So what does that mean? Well, these are the rules of property. How do we determine ownership of property? Contracts. How do we make contracts? How do we do transfer of goods and services? What we're really looking at right now is trying to make a decision about whether access to healthcare is one of these basic social institutions. Is it a foundational structure? And is access to healthcare a right? That's part of the ethics question we are grappling with. Now, it'll help us to think about rights. There are negative rights. So what do I mean by that? These are rights to non-interference. These are things like, this imposes a duty on others to leave you alone, not bother you. Examples are your right to free speech, your right to gun ownership. Not every country has a right to gun ownership. Your right to vote. You don't have to exercise your right to vote, but no one can interfere with your right to vote. We oftentimes think of these as our constitutional rights in America. We have strong sanctions for violating negative rights. And it's funny because it's negative is not meant as a negative, but rather as a very strong right. Once we reach social agreement on it, what a negative right is, we enforce it. We defend that right. Now, a positive right is a right to a benefit. This is where the government in a negative right has a duty to make sure you're not interfered with, but they don't have to they don't make you vote. That's your privilege. In contrast, a positive right is something that the government has a duty to provide to you. It's a benefit. An example is education. In the United States, we define that as up through 12th grade. Other countries define it differently. In France, in some other countries, it's through through postgraduate education. Examples also include clean water and clean air. These are things that we see ourselves as having a right to and the duty of the government to provide. Now, there's a weaker individual duty for us. And what I mean by that is my right to education doesn't necessarily impose on any of you a duty to give me money for that, right? You didn't have to pay for my college education, although I did go to public institutions, so you sort of did. However, a negative right imposed on me a duty to not, imposed on all of you, a duty to not interfere with my right to vote. So negative rights are generally stronger in that sense than a positive right. And let me put it into a healthcare term. You have a right to be left alone. That means you can refuse a particular healthcare treatment. You can refuse excessive care, what you might view as excessive or aggressive care at the end of life. And that's generally stronger than a right to receive health care. Okay, so rights, negative and positive rights. Now there also are human rights. These are the inalienable rights, just that we get just from being a human being. So, what are those? Right to liberty, right to security, to life, freedom from slavery and servitude, recognition before the law that we are people who have a position in the law, in the sense that we can argue our case before the law. We have equal status. The United Nations, in their Article 25, says that everyone has the right to a standard of living adequate for the health and well-being of himself and his family, including food, clothing, housing, and medical care, and necessary social services. So this brings us to think about, again, is healthcare a negative right? That's how we've defined it in the U.S., that it's a right that people have the right to access, but the government does not have a duty to provide. Or is it a positive right? Something that we have a duty to have provided to us, like education. Is it a human right? Is it something that is, and is it a basic healthcare and inalienable right? That is what we are faced with thinking about as a country. Well, I always use cartoons to figure out what are we thinking about that. We fear that some people are saying healthcare is not broke, why fix it? And who are those people? Well, they're health insurance companies and CEOs. But here is Grandma, got healthcare reform, and she's saying to the healthcare insurer, your excuses for not providing me coverage have been denied. So our fears coming out here, that they're making decisions for their profits, not for our good. And yet, who will pay for it? Here is the wealthy, here's the wealthy, now you're getting to see the clicker. Have to use the, yeah, there we go. So the wealthy concerned that that the tax increase is going to disproportionately affect them, right? That it's going to be a real shock to absorb. And then the worry that in fact we're spending all this money and it's for over-treatment, right? That we're treating hangnails with far too much health care. And the additional worry that we are literally paying for our goals. Quite literally. See, straight to the ATM. So this helps us to get a sense of what are our concerns. I mean, I do find cartoons really get to the sense of what do we worry about? We're worried about what are our rights, who's benefiting and has a conflict in terms of doing that right. Is it a positive right, a negative right? And will we be left in this bed again? Well, you know, I look out at you and most of you are probably in the boomer generation or something past. Okay, I wasn't going to say that. So we'll just say boomer generation. Well, how do boomers see their future? You know, there they are. There we are. With Social Security, with Medicare, with our 2.5 children, notice their daughters, assisting in our old age. Well, when we think about that, we have to realize, we have to think about who are those 2.5 children. And they're, to a large degree, the millennials, right? The boomer, the echo booms, the baby boomlets, or my favorite, the Y generation. All right. So what is this generation like? Well, they're the majority of college students, and I have the privilege of teaching them. And I want to just thank you all for sending your sons and daughters and grandchildren, because this is a fantastic generation, and it's truly an honor to be with them. They're the most culturally diverse generation in American history. They are digital natives. You know that cell phone that seems to be surgically attached? Well, they are so smart. Cell phones and computers come naturally to them. They speak digital. We speak with an accent. Their generation is bookended by the Challenger tragedy and 911. They value public safety, and they also value saving money. Very surprisingly, perhaps, for us. They're civic-minded and highly educated. One of the reasons I'm here today is because when I told my 16-year-old daughter that the League of Women Voters had asked me to come speak, she dropped her jaw and said, "Mom, you have to do that. You have to go speak on healthcare reform and speak to voters." Would I have said that at 16? Well, what are their worries about the future? What do the millennials? You know, there's fewer of them than there were of us. That 2.5 children, there's a tsunami of elderly hitting America and actually across the industrialized world. And they are worried about how to support, they love us, but how to support the Medicare, the Social Security, and the care for us. So how do we begin to sort out how we make decisions among groups, among needs? And one helpful concept, again, is the veil of ignorance. When we think of justice at its most, perhaps simple, as the concept of fairness, how do we begin to make a decision about what's fair? There's so many things, as you know, in healthcare that we have to offer. How do we weigh which to offer? Well, the philosophers have said that the important thing is conditions of equality. Now, some philosophers, Locke and others, have said, as free and moral human beings, we can judge fairness. We can stand in our shoes and judge that. And others, such as Rawls, have said, no, that's impossible. We stand and we look through our own glasses, through our own privilege, through our own needs, through our own benefits in life. And we need to instead assume that there are unfair conditions. The solution to determining those terms of the social contract, okay, remember back at those social institutions, the solution to determining that is to somehow have a way to not know what your own health and wealth would be. To somehow set that aside and judge fairness, not knowing that. And that is the veil of ignorance. That fairness can only be judged from behind this veil of ignorance, not knowing what your specific situation might be in the system that you're trying to weigh. So what do I mean by that? Tristan Engelhardt, a libertarian philosopher, has talked about the natural lottery and the social lottery. We all win and lose. The natural lottery, one of the first questions, if you've ever done those tests that say, how long will you live? One of the first questions they ask you is, how long have your relatives lived? Do you have anybody who's lived to be in their 90s? So our genetic history is something that we win or lose in terms of the genetic lottery. Our family health history is something that we have very little control over. The diseases and accidents we might have in life, whether we were born and had a difficult birth and have cerebral palsy, whether we have an accident, a motor vehicle accident that leaves us with a spinal cord injury. Those are things that are the natural lottery. I look out at the audience and I see that all of you seem to share a genetic disease. You appear to me to be melatonin deficient, which means you're at risk of melanoma. And should we have a healthcare system that says we don't treat melanoma? Because if you took better care of yourself, you wore a hat, you wore sunblock, long sleeves, then you would not have gotten melanoma for your natural condition, which is not having enough color in your skin. Now the social lottery, we can also win or lose. You know, if you win the social lottery and lose the natural lottery, you can still have a pretty good life, right? If you have diabetes, but you're rich, you can afford the best of care. If you're not so rich, but you're really healthy, you can also have a great life. But the social lottery is that socioeconomic status that we are born into, and our luck, that we're not injured physically or socially by a third party. We're not the victim of violence. We're not sued in a way. We're not involved in a lawsuit. It's also this historical time, the baby boomer generation versus the millennials. That we are in a country that has war, but does not have war on its own soil. Very different than if we'd been born into a country at war. Being at recession versus prosperity. Sorry. So this gets us to ask, is this unfair or merely unfortunate? The social and natural lottery. And that's really where we have to begin to say what is justice. If a condition is unfair, we have a social duty to mitigate it. And the way we think about that is that the greatest benefit needs to go to those who are the least advantaged, the poor and the ill. Those in need should receive more. If a condition is merely unfortunate, then losing the natural and social lotteries does not imply that claim to our privately owned goods, our money, to help resolve that disparity, nor to communal resources, unless we blame somebody else. Now think about our society and the relationship between compassion and blame. We have medical malpractice so that people can cover their health care costs. We have public health where we spend the 90-10 rule. We spend 90% of our dollars on education, when in fact 90% of health issues are not about personal choice. They're about the situations that we have little control over. Clean air, clean water, etc. And then personal responsibility. I'm going to let the other speakers talk about that issue more. So another quick concept, rationing versus allocation. Rationing is when we have to choose between scarce resources. The H1N1 vaccine this last year was originally scarce. We only had a certain amount of it. We had to decide who got it first. Was it healthcare workers who were on the front lines? Was it people who had immunocompromised for whatever reason? Solid organ transplants. We only have a set number. That's not what we're doing when we think about healthcare reform. We're not rationing. We're allocating. We're deciding how to spend the healthcare dollars we want. And as you've already heard, we're already spending 50% more than anybody else in the world. Are we spending them the right way? And the example is on end-of-life treatment versus childhood immunizations, on cardiac disease versus renal disease versus prenatal care. So the types of justice. Strict egalitarianism would say we all get the same amount. But what if some need more and some want less? Or some want less and some need more? I said it the wrong way. But you know what I mean. Distributed justice. That's where the goods are distributed fairly according to criteria. But what criteria? Health needs, social worth, age, and then utilitarianism, another common theory that you've heard, goods distributed to achieve the greatest good for the greatest number. But who decides what is the good and who counts? All right, so principles and values. These are the four common principles you hear: respect for autonomy, beneficence, non-maleficence, and justice. We also have some values that we think about: veracity, honesty in healthcare, confidentiality, privacy, and fidelity. The question is, are we missing a principle in the U.S. when we think about healthcare reform. And many people in other countries would say we are. That we, in our debate, don't include an important principle, and that is solidarity. Sometimes it's called communitarianism, and it roughly translates to this: it harms me if you don't have enough. You might have seen this recent article in the paper. This is an example of solidarity. Should firefighters putting their lives on the line and who work enormous numbers of hours, but in a relatively short period of time, should they have health insurance? Does it harm us if they don't have enough? This brings us to, and I grew up in a small town. My parents lived outside of Missoula, Montana, because they thought Missoula was far too large to raise children in. So I understand the privilege of living in a small community. And you are in a particular position to think about ethics for neighbors, not for strangers, not for that uninsured who is a stranger, but rather for the daycare worker you take your kids to, for the barista you buy that latte from in the morning, for that seasonal firefighter. So Martin Luther King said, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. That sounds really easy to sort out, but in fact, that's what we're trying to figure out. What is unjust? And how do we create equality? We have a historic opportunity to think about this, but I want you to think about, what is our social contract? Is access to healthcare a right, and if so, what kind? Negative, positive, human? This natural versus social lottery, and how do we account for that? Where does our duty lie? Allocation of healthcare resources, not rationing. We're not rationing, we're spending plenty. And then last, neighbors, strangers, and solidarity. Is there a principle missing from our dialogue that we want to include in? Thank you very much.
Our next speaker is Dr. Rebecca Corley, known to some of you as your doctor, perhaps your colleague, your neighbor, or your friend. Rebecca Corley has practiced pulmonary and critical care medicine in Sequim and Port Angeles since 1998, having practiced in Vancouver, Washington for 10 years prior to that. She worked for Virginia Mason before forming Coastal Medical Group in Sequim in 2002. She joined the newly formed Olympic Medical Physicians in 2007 and was the medical director of the Sequim Specialty Clinic until accepting the position of Chief Physician Officer of Olympic Medical Physicians in 2011. She provides hospital and outpatient services in the specialties of pulmonary and critical care medicine. She is a board certified in internal medicine, pulmonary, and critical care medicine. She is well known by countless patients and their families as an excellent, caring, and trusted physician. Dr. Corley is going to discuss ethical and moral issues from the perspective of a practicing physician. Rebecca Corley.
Well, I want to start this evening by thanking Bertha for asking me to speak today. It really gave me the opportunity to really think about this subject over the last several weeks. And it also gave me the opportunity to talk to a lot of my friends, my colleagues, and even some of my patients about the ethical and moral issues surrounding access to health care. I think
Can you hear?
Oh, yeah.
Are you okay?
Yeah.
Okay.
And what I found in talking to people, there was a huge variation in opinions. But in each and every conversation, it always came around back to politics and the fact that this is a presidential election year. Now, I work for Olympic Medical Center, and my slides will reflect that. But I want you to know that the opinions you hear from me tonight are really my opinions and not necessarily those of Olympic Medical Center's administration or our Board of Commissioners. So I'm free to say anything that I'd like to. What I'd really like to touch on tonight is kind of three areas. The first is treatment of emergency medical care. Number 2 is a little bit about rationing, and number 3 is prevention. We at Olympic Medical Center treat all patients that walk in through our doors for any emergency that may arise. This is true in our emergency room, in our hospital. We also, on May 1st, opened up a walk-in clinic in swim to take care of the urgent care needs of the swim community, although we welcome Port Angeles residents as well. But it's not at no cost. In 2011, we spent $9.3 million in uncompensated care. If you look at that as a percentage of our operating revenue, it doesn't take an economist to see that uncompensated care percent is going up. What we're finding is that in our emergency room, we're pretty stable in who we're seeing. In our critical care unit, we're pretty stable in what we're seeing. But in our hospitalizations, especially for elective things, the numbers are way down. It appears that people are putting off their elective procedures, their screening procedures, and the people we are seeing are much, much sicker. It doesn't take very much to realize that as our expenses are going up, our uncompensated care is going up, and our reimbursement is coming down, that this is not sustainable. It was the recent Census Bureau said that our community had 14.4% of the population living below the poverty level. June 20th, the PDN reported that our unemployment in the North Olympic Peninsula was up to 10.4, and we know that about 10% of our residents are uninsured. Now the question becomes, why should we care about that? Well, number one, I just mentioned that as our reimbursement is coming down, our costs are going up, our uncompensated care is going up. That's not sustainable into the future. But if you want, just from a purely selfish, I have insurance, so why should I care about the fact that there's many people that are uninsured? Well, there's something called negative spillover. So if we're kind of happy that we have insurance, there was a study in the Journal of Health Economics recently that reported a spillover effect from allocation of resources. And what this study found is that if you have a heart attack, you are more likely to survive if those around you have insurance. The higher the percent of uninsured, the more likely you are to die of your heart attack. And in fact, they concluded that if it was national health insurance coverage, that the decrease in heart attack deaths from uninsured individuals would be a decrease of about 3 to 5%. And it's called negative spillover. So the resources that are spent on uninsured individuals leave less resources for other programs and treatment of insured individuals. Now I'm going to touch a little bit now on rationing. If there's anything that brings gut-wrenching concern to providers, it's the mere mention of rationing. And there's both what I call formal rationing and informal rationing. An example of formal rationing is the Oregon Health Care Plan, and I'm sure many of you have heard about it. It began in 1994 as an effort to improve access to health care in the working poor, ration benefits, and put more emphasis on preventive care. In the very first year, there were 120,000 new enrollees, and it decreased bad debt in Portland hospitals by 16%. But the Oregon Health Care Plan has not been without controversy. Rationing is very hard. An example of one of the controversies is that I'm a lung doctor. In 1998, because of further budget cuts, there was a decision made that if you had cancer, including lung cancer, and had less than a 5% chance of surviving 5 years, your treatment was not covered. Comfort care was covered, but not treatment. That came right at the same time. There was a new class of medications released that for lung cancer didn't cure it, but for many individuals would take your life expectancy from a few months and increase it to 6 months, 2 years. And it's issues such as that that have really caused a conflict, I think, in us that are providers. You've all heard of the Hippocratic Oath. And just taking the Hippocratic Oath and narrowing it down into three main things. The first is treat the sick to best of one's ability. This means not only giving a treatment for a known ailment that we know is going to work, but also withholding treatment that's not, that we know won't work or maybe will harm the individual. That becomes a conflict. In order for me to be a patient's advocate, I need to have the tools to treat that patient. There's a medical arms race going on. Our ability to treat medical illnesses is incredible in this day and age. I started medical school in 1980, and it is amazing what has happened. We have taken death in HIV/AIDS patients and turned it into a chronic illness. We're curing childhood leukemia. The advances we've made in diabetic and many other disorders are incredible. But that costs a lot of money. And as more and more technology becomes available, we're spending more and more money in research and development with very, very good outcomes. But this is at the same time we're being told that we need to have affordable health care and to cut costs. And that really sort of is coming up against each other. I have personal conflicts. I spend half my time being an administrator for Olympic Medical Center with Olympic medical physicians. So when I wear my administrative hat, my job is to look at the health of the community, to help to cut costs, to be efficient in what we're doing. But when I put on my hat of an individual physician and I'm sitting with a patient, the most important thing I have is to treat that patient. And all I should worry about is giving them the best care and the best treatment that I can. If I go back to that case that I was talking about with the Oregon Health Care Plan, the fact that if you have less than a 5% chance of surviving 5 years with your cancer, it won't be treated. Well, if I have a patient and there's a medication that I know that they're going to be dead in a few months, it's a very difficult situation for them, obviously. And then there's a medication that may help for them to survive 6 months or 2 years. Life is about milestones. It's about meeting one goal after another. And for that person, it may mean getting to the birth of a grandchild, seeing their son graduate from high school, seeing a relative that they haven't seen in years. So for all of us as a community, the cost of that medication, which is about $1,000 a pill, the cost of that medication may not make sense, but to that individual who's receiving the medication, it's huge. Most of you probably know that we have a primary care access problem in this community. A lot of it has to do with some of our reimbursement challenges, our aging population. It's resulted in the increasing use of the emergency room. I am happy to say that the 3 largest groups in SWIM and Port Angeles Family Practice Group are in pretty much a continuing recruitment mode to try to bring in more patients. I mentioned formal rationing with the Oregon Health Care Plan. I think that informal rationing is much, much more common. Every day in our offices, we're making we're making recommendations for treatment, and people cannot afford that treatment. There's not one day that goes by in my practice that I recommend a medication that a patient cannot afford. And so either we're not able to use those medications or we're having to go with much cheaper alternatives. One of the orthopedic doctors just told me about a case where a 30-year-old working father of 2, catastrophic insurance, had a deductible of $10,000, dislocated his shoulder and was refusing to go to the emergency room because he just couldn't afford it. So rationing is happening every day in our practices. It's really my belief that one of the keys to cutting healthcare expenses is to really focus on prevention. This is just a very few of the things that we can do. I could write pages and pages of things. I'm not going to talk much about these other than saying each and every one of these has a cost. Most of these are not reimbursed, or many are not reimbursed by the insurance companies. But the benefit to us, keeping people healthy, far outweighs any cost. And I think many of these are where we really need to focus on. So in conclusion, I'm just going to give you two commercials. My first commercial is as a pulmonologist. I just said that all of these cost money. Well, I'm going to tell you about one major health prevention that's absolutely free. And that is the banning of smoking in the workplace and other smoking restrictions has been the _1 thing that has decreased the incidence of smoking in our nation. #1 cause of #1 reversible cause of healthcare problems. In the 1950s, as many as 57 men smoked cigarettes. It's now down to 22%. The second commercial is just to give you my personal belief about healthcare access. I believe that if we do not furnish healthcare to all, that the costs are going to continue to go up. Patients are going to present sicker, with more adverse outcomes, and at much higher cost. If we say that there is not an ethical and moral obligation to provide health care to everyone, that is implying that one life is more valuable than the next just because one person can afford health care and the other can't. And it doesn't even address the millions of children that don't even have the ability to go out and purchase health care. So I really do believe that health care decisions, whether it be who gets health care, how we prioritize it, or how we ration it, needs to be evidence-based and not based on one's ability to pay or your income. So I thank you.
Thank you, Rebecca. Our next speaker is Phyllis Darling. Phyllis moved to the peninsula with her husband 12 years ago after living nearly 40 years in Las Vegas. She immediately engaged in the community when she became the director of the Olympic Peninsula chapter of the American Red Cross. Phyllis has a Bachelor of Arts in Social Science and a Master of Arts in European History. Phyllis began her career as a teacher of government and history and soon moved into administrative roles that included being the Director of Social Studies, Clark County School District, Director, Nevada Center for Law-Related Education, School Principal, and National Consultant to McDougall Lytle Book Company. She and her husband have a son who is a graduate of West Point and a lieutenant colonel. Phyllis will present from the point of view of individual responsibility and individual freedom. Please welcome Phyllis Darling.
Thank you, Bertha, and thanks for the opportunity to get up and share the opinions of a group of people not necessarily associated with the League of Women Voters, but who recognizes that the League of Women Voters represents everything that individual rights and responsibility means. It is concerned groups of citizens coming together in voluntary association to address the needs of their community. So we're grateful to have you and grateful for the opportunity to speak today. You may have heard that I was a history teacher in that brief intro there, and there's good news and bad news today, guys. Once a history teacher, always a history teacher, so you're going to get a little history lesson. That's the bad news. The good news is no test at the end. Just relax. In the early 1800s, a Frenchman curious about how the baby democracy across the ocean was faring began to travel across America. The results of his travels was a book, Democracy in America, which has become a classic commentary about the United States. Alexis de Tocqueville found to his amazement that Americans faced with a problem in their communities looked not to the government for their solution, but took the bit in their teeth by forming organizations dedicated to solving the problems. Farmers created granges to organize collecting, selling, transporting agricultural produce. Community subscriptions financed roads, bridges, canals. Religious congregations fed the hungry, nursed the sick, interred the dead. Americans, in all their optimism, energy, enthusiasm, and dedication to democracy and action, had created a tradition of social responsibility and action. The great documents of the American heritage, the Declaration of Independence, the Constitution and the Bill of Rights, have bequeathed to us a legacy, a precious legacy, of individual liberties and responsibilities, which have encouraged Americans to come together in voluntary association to improve the quality of life in our communities. This tradition has survived to the present. Look around at our little community, our Port Angeles, Clallam, our little communities on the peninsula. You will find an astonishing array of volunteer organizations, each with an emphasis on a particular social need. The service clubs, Kiwanis, Rotary, the Elks, the Seroptimists, and et al., devote thousands of hours and many thousands of dollars to serving this community. The recent Operation Pink Up is a perfect example, for instance, of a community-wide volunteer effort to address health care for women. Volunteers in medicine provide health care for the uninsured. You notice that this is in Port Angeles, but there's one in Sequim as well. Food banks make sure that no one need go hungry. And overarching all is the United Way, which makes sure that community needs are identified and donations funneled to a wide range of services and needs. And I see our wonderful director of United Way sitting in the audience there. Hi, Jody, welcome. Thanks for coming tonight. Many of you remember the terrible polio epidemic, which swept America in the mid-19th century and killed hundreds of thousands of children, crippled millions more. As Dr. Jonas Salk worked in his laboratory developing the vaccine which would eventually eradicate this disease, he was supported in his work by millions of privately donated funds. Polio was completely eliminated by a combination of private individual researchers and donations of millions of Americans donating their dimes to the March of Dimes. You remember putting the little dimes in the slots when you were a child? I put a number of dimes in myself. Well, all those dimes added up to millions of dollars, and all those millions of dollars added up to curing polio. In more recent times, Rotary International has virtually eliminated polio in every country of the world, including the poorest nations. We are just wrapping up India right now as we speak. How was this accomplished? By private citizens organizing, donating their money, time, and energy to the project. To return to our town, my husband and I had barely settled in Port Angeles before I was recruited by my own service organization to build a playground. It was explained to me that the children of Port Angeles had asked for a playground with a dragon and a boat and a fire engine and all the things that little children wanted. The Kiwanis Club of Port Angeles spearheaded the drive to raise funds and organize labor. As I worked alongside my new neighbors, it seemed to me like the entire town had turned out in a literal labor of love, and how proud and happy I was to live in a community like that. A further dividend accrued when my little grandson visited, and as he slid down the dragon, was vastly impressed that Grandma had built that dragon. The dream playground, indeed. Which brings us to the issue at hand. If providing health care were as simple as building a playground dragon, we wouldn't be wasting our time here in this forum. The fire-breathing dragon, which is the effective and affordable deliverance of health care, can literally be a matter of life and death, and is always a matter of the quality of life. This form asks the question, is healthcare a right or a privilege? It is neither. Healthcare is a commodity, a very important commodity, to be sure. Perhaps not as crucial as the commodities of food and shelter, which we all have to buy for ourselves, but certainly ranking right up there. And in the ongoing debate between individual responsibility operating in voluntary association and government control, I have been given the opportunity in the cliché to look at life from both sides now. For the first half of my life, I worked for and in government institutions as a public school teacher and an administrator. My second act was spent in the private and service sectors as a private school principal, national consultant for McDougall Littell Books, and executive director of the Olympic Peninsula chapter of the American Red Cross. The contrast between the efficiency, the effectiveness, and the fiscal efficiency of the public and private sectors was a real eye-opener for me. Because you are all familiar with the Red Cross, let me use it to illustrate a point. You know that the Red Cross is a disaster relief organization delivering food, shelter, clothing, medicine, and mental health services to disaster victims. But did you know that not $1 of the hundreds of millions of dollars in annual Red Cross funding comes from the government? Every single dollar is privately donated by the American people, who are pound for pound and dollar for dollar the most generous people on the face of the earth. We give, both on per capita terms and in absolute terms, more money to private charities such as the Red Cross than any other nation on earth. And we don't just give it to our own people. We see that it spreads around the world as well. That Rotary effort that's funding the wiping out of polio is a good example of how American dollars go to help health, not just in our country, but in other countries. Every dollar is privately donated, and let me tell you, when you have to go out and convince people that you provide effective, needed services, when you have to raise every dime yourself, you make sure that these services are provided efficiently, and you get a huge bang out of every buck. You all remember Hurricane Katrina, I think, one of the most destructive natural disasters in our country's history. Katrina was not a surprise. New Orleans, for an example, had 3 days' notice to get its population living in potential flood areas to high ground. Neither the state government nor the municipal governments used this lead time to make arrangements for evacuation, let alone to actually move the populace out of harm's way. As a result, people died, people suffered. When survivors who were plucked off of rooftops were asked why didn't they use the 3 days warning to get to safety, many of them replied that they were waiting for the government to come and get them. People in the area were so used to the idea that the government would take care of them that they had lost their capacity for individual action and rational response. Do not underestimate the negative effect which the constant abrogation of individual rights and responsibility to the government has on the ability of people to live their own lives in a rational manner. And who were the agencies who provided for the survivors? Well, of course, the Red Cross, which gave direct financial aid to every family, set up shelters and staffed them with disaster volunteers from all over the country. These people, disaster volunteers, train at their own expense, go to the areas that are affected without pay, and live in terrible conditions for weeks and sometimes months, and sometimes, in the case of huge disasters like 9/11, for years. They don't expect pay and they don't expect thanks. They do it because they owe their fellow human beings this care and this support and this relief. Religious congregations after Katrina, including the Southern Baptists, who brought their mobile cooking station and served 250,000 meals after Katrina. The American people, who in their never-failing generosity and concern for their fellow citizens donated just under $1 billion in the space of 1 month. In a matter as crucial as healthcare, though, it is not enough to say that government is the least desirable mechanism to provide this important commodity. We must offer workable and cost-effective alternatives, of which there are a number readily available to us, immediately available to us. Tort reform, very important. Tort reform would save us billions and billions of dollars annually in unnecessary defensive medicine and malpractice insurance premiums. You may remember a few years back when a clinic in Eastern Washington completely closed down because the 4 doctors who worked there could no longer afford to pay malpractice insurance premiums. Well, tort reform would address that problem. It wouldn't cure it, it would solve it, but it would certainly address it. Allow people to purchase health insurance across state lines. Competition works. If health care were a car in the state of Washington, you would have to buy a car which was manufactured in the state of Washington, which had 500 horsepower, 8 cylinders, cost $75,000, and that would be it. I mean, you had to buy it. You couldn't go to Detroit and buy a Chevrolet. God forbid you couldn't go to Korea and buy a Kia. You would have to buy it here. Well, this is the state of healthcare today. States do not allow, in most cases, people to cross state lines and buy health insurance. So there's no competition. There is no comparison of costs, and you're stuck where you are. Think of the dollars you could save if you could have competition in health insurance. Eliminate expensive minimum coverage premiums that prevent healthy people from choosing much less costly catastrophic insurance. For most young people who are basically quite healthy, you don't need the constant care of degenerative disease, medicines, services, medical intervention. But you do need, for instance, prevention from, let us say, cancer, to give the most obvious cause. That is a much less costly insurance than covering every single possible condition that could possibly come up. Free up the import of cheaper drugs from abroad. There's no reason, for instance, why we should think that drugs coming from Canada are any less safe than drugs coming from the United States. And if we did, well, that would be our choice. It would be a commodity that we would purchase, and we would make the decision, not the laws which prohibit us from doing that. In short, before we hand over health care to an organization which combines the efficiency of the post office with the compassion of the Internal Revenue Service, let us utilize the private sector alternatives which preserve our freedom, encourage rights and responsibilities, and true social action for the common good. Thank you.
Our final speaker is Dr. Mary Wegman, who has lived in our community since 1974, fulfilling a number of roles. Dr. Wegman holds a bachelor's and 2 master's degrees from the University of Wisconsin and a PhD from the Fielding Institute. She practiced clinical psychology in Port Angeles from 1992 until 2008. She worked for New Growth Behavioral Health Services, which she co-founded. Her clinical subspecialty was neuropsychological services, including assessment of learning disabilities and dementia, and supportive services for individuals with neurological conditions. She taught psychology at Peninsula College from 1980 to 1990 and became a sought-after speaker on psychological topics to many local organizations. Now retired, Mary devotes much of her volunteer time to Prevention Works, a community coalition of Clallam County, and her duties as a member of the Clallam County Substance Abuse and Mental Health Advisory Board. Mary will present the point of view of societal responsibility and common good. Please welcome Mary Wegman.
Thank you. I'm delighted to have this chance to share some of my thoughts. And just as Dr. Corley said, although I am a member of the League, and I am a member of the Healthcare Committee that has put on these 4 forums, what I'm about to say really represents my own personal beliefs. Here we go. This is what I believe. Our current system is unfair to millions of Americans. We are a nation pledged to equal protection and fairness, yet our current healthcare system is broken. It gives some of us access to health care and leaves the remaining citizens out. Any reform of our healthcare system must come from a principled approach. That's what I believe, supported by a moral view of our relationship to each other. I believe the only principled approach that results in an ethical and morally defensible position is for universal health care. I was asked to comment on, is there a moral imperative to change our system? Yes, I believe so, and I'm going to use a bunch of numbers to explain why, so bear with me why I believe that. The original American plan, many of you know, was to receive your health care coverage through the place you worked. In our state, right now, 44.8% of private sector businesses do not offer health insurance to their employees. Nationally, it's 55.4%. That's a lot of people working full-time who do not have access to health care through their workplace. Who are these people? You can guess as well as I can. They work for small companies, small offices. They're individual contractors. They drywall your home. They build your decks. They cut your hair. They give you massages. They wait your table. We could go on and on. Are they less valuable human beings? Do we in our society say, even though they're working full-time, they're less valuable human beings? They don't deserve health care access because of the jobs they have? Considering all the sources of health care coverage, workplace insurance, Medicaid, Medicare, private insurance, what percent of Americans currently have no, nada, none health care coverage of any sort whatsoever? I'm going to give you an answer, but before I do, I want to ask you, think, what is morally acceptable? What percent of Americans that don't have access to health care, what would you accept? 1%? Would you say, I could live with that? 5%? 10% of Americans? It's getting a little dicey. Does that feel fair? Well, currently it's 17.1% of Americans. That's of February of this year. About 1 out of 6 of us. The 17.1% of Americans who do not have any kind of health care coverage of any sort translates into 53 million of us. Now, I find that hard to put my mind around that number, 53 million, so I'm going to try to help you out here. That's more uninsured Americans than there are people living in all of Canada and all of Sweden, all of Denmark, and all of Norway combined. Let's try a different number. 37% of all Americans are now reporting, according to a recent poll, that they're going without health care because they can't afford it. Many are saying they do have insurance, but they can't afford the copays. They can't afford the huge deductible. They can't afford the medications. 37%, that's almost 2 out of every 5 of us. Is that okay? How many people die in the U.S. every year because they don't have health care coverage? Harvard Medical School conducted this study. It was done and completed and reported in 2009. I believe, but I can't say for sure, I believe the numbers are bigger than what they found in 2009. At that year, It was 45,000. Let's try to kind of wrap our minds around that number. I want you all, how many of you have ever been in a Boeing 747? Okay. I want you to imagine a Boeing 747, and I want you to fill it. Let's put 400 people in it. Okay, you with me? That Boeing plane takes off, and shortly after it takes off, it crashes, and all 400 of those people die. It's a very horrible image. But I'm not done. Now I want you to do that every third day, all year round. That's 45,000 people. How long would we put up with a Boeing 747 crashing every third day? How many of those crashes would we accept before we say, there's something wrong here? We're going to ground that Boeing 747 until we figure it out. A few more statistics. In 2010, 922,819 American citizens declared bankruptcy due to medical bills. I'll help you with that one. That's 105 bankruptcies every single hour of every day. This is outrageous. In any given year, 50% of all our personal bankruptcies in the U.S. are due to huge medical bills that can't be paid. What about our local numbers? Rebecca, I got numbers a little bigger than yours. I looked up the Insurance Commissioner's webpage, and as of December 2011, there were 9,609 residents in Clallam County without any health care coverage at all, and about 904 children in our county under 18. Our system of providing health care coverage to all Americans is so inadequate. If you're an American without health care coverage, it's like being in a car crash and, oh my God, discovering to your horror that the airbags in your car are made out of tissue paper. We are an outlier. No other industrialized nation is without health care for all. No other industrialized nation allows people to die just because they don't have financial resources to buy health insurance. Do I feel there's a moral imperative for us to change our system? You betcha, I do. Some say, hey, isn't it everyone's individual responsibility to take care of their own health care needs? Why am I responsible for someone else's failure to live right? I strongly support people living healthy, paying attention to their health care. But do we really want to live in a judgmental society where we exclude some people from universal health care coverage because they don't do a good enough job taking care of their bodies? Where would you draw the line? Would you say, let's not pay for all those people who smoke? Or would you say, let's not cover all those people who are overweight by 30 pounds? The personal responsibility argument starts to fall apart also when you look at the 4 factors which statistically play the largest role in the cost of health care. Genetic conditions, premature birth and childhood diseases, accidents and injuries, and the health consequences of living in poverty. The whole point of health insurance is to spread the risk so that everyone is covered. Everybody in, nobody out is the only socially fair approach. It spreads the risk amongst all of us. It removes the punitive element. It doesn't discriminate against anybody. I considered some of the most common arguments against universal health care, and I tried to think about them in a moral and ethical framework. I probably won't be able to get through all of this, but let me mention a couple. Some of you out there might be thinking, universal health care costs too much. We can't afford it. Of course we can afford it. Of course we can afford health care for all. We are the richest country in the world. We just need to figure out how we're going to do it. What is it about America that allows so many of us to say we can't afford it when every other industrialized nation in the world provides it? By the way, those countries are doing something right because their healthcare outcomes are better than ours. We currently rank 37. How is it that they can organize a system that works and we cannot? Are we less intelligent than them? Is that what it is? I don't know how we're going to pay for universal health care. That's for others to figure out. Many suggest that administrative savings alone from a single payer system would result in about 100 to 150 billion annually in savings. Some people say that would be enough to cover all the uninsured. What I do know is we can afford it. Some people talk about rationing. If we shift to a universal health care system, think of those 53 million who are not currently covered. That's going to put a lot of people into our healthcare system, and our care will surely have to be rationed. Well, yeah, I mean, that's probably true. Not every single desire for every single treatment known to man will be available under healthcare for all. But that's true now. That argument only has weight for me, only has legs if you assume we do not have rationing now. And I'm going to skip explaining how because my time is running short. We can talk about that later. Compare in your mind the moral weight in one hand, everyone in the country having access to health care. No more 747s crashing every third day. Versus on the other hand, if we have everyone in, I'm going to have to wait 4 months to get my rotator cuff repaired. I use that 4 months because that's what the average amount of wait time is in Canada, who does provide health care for everyone. It's clear to me providing universal health care carries much more moral weight than a small delay to have an elective procedure. Some say universal health care system will require everyone to pay in. Yes, it will, even if we're not using health care services. And that's a violation of my personal freedom to choose how I spend my money. Well, I don't agree with that point of view. If we took that point of view and took it seriously, then that means, boy, if I don't have kids in school, I don't pay school tax. If I don't use parks, I'm not going to support parks. If I don't drive a car, I'm not going to support roads. If I don't go to the library, I'm not going to support the library. And if I don't fly, I'll be darned if I'm going to support the FAA and airports. This approach totally destroys our common sense, our sense of the common good, being a nation gathered together for common purpose. Here is what I believe is the real freedom that we Americans want. As patients, we want to be able to choose our doctor. We want to be able to choose our specialists, our hospitals. Most of the countries that have universal health care give people that choice. Our closest neighbor, Canada, does. They have the choice to choose. Some people say, let the market system solve this. Let the free market system. I have a lot of respect for the market system. But the market system does not have an ethic that requires a focus on the common good. Here's a little comparison that points out one. There's many reasons why the market system will never provide health care for all Americans. I want to compare the salary of the director over here for the center that controls Medicare, the Center for Medicare and Medicaid Services. And then I'm going to compare his compensation with that of the CEO of Aetna. Medicare covers about 48.5 million of us. The director of Medicare, I honestly don't have a clue how much he earns. I tried to look it up and I couldn't find it. But I know it's less than $400,000 because that's what the president earns, and he is the highest paid official, federal official. So I'm going to make a guess. He earns $300,000. Are you with me? $300,000 overseeing 48.5 million of us. And I did mention he also oversees the Medicaid programs in all the states. Aetna covers about 18 million people. 300,000. The Aetna CEO of Aetna, according to Forbes, has a compensation package of 24 million. And he's not alone. Huge salaries for all the top management of American health insurance companies with huge expense accounts, huge lavish corporate headquarters. That's the norm. And in the free market system, that's okay. It really is okay. But it doesn't serve the common good in the country. The market ethic holds that healthcare is merely a commodity to be bought and sold at a profit, like a television or a set of golf clubs. But you know, in our society, some aspects of life are off limits to commerce. We prohibit the selling of human beings. We prohibit the selling of children. I believe that healthcare is too precious, too intimate, too central to the well-being of our nation to entrust market forces. In closing, I believe in universal health care because I think it's good for America. I believe health care for all is an ethical position involving the relationship of all of us to each other and our mutual sense of obligation to each other. Without that common sense of caring, we are a lesser nation, a more selfish nation. Michael Sandel, in his much acclaimed book, Justice, and it's on your bibliography, wrote, "A just society requires a strong sense of community, a concern for the whole, a dedication to the common good." Paul Krugman recently wrote in an opinion piece, it was in our paper, "It's one thing if the rich can afford bigger houses, luxury cars, or fancier vacations than ordinary families. Americans can accept such differences. We do so cheerfully. But a society in which rich people get their medical problems solved while ordinary people die from them, it's too harsh, even for us. Everybody in, nobody out. That's what I believe." Thank you.
Okay, I'm going to ask our speakers to come and take their positions at the table. And Sarah Shannon is going to help us, or she is going to facilitate a panel discussion. So, Rebecca, Phyllis, and Mary.
I'd love to start off just with asking the panelists, and you're going to have a chance to also ask, but I'm hoping to be your spokesperson for a few minutes. What do you see as the role of personal responsibility? Many of you talked to the issue of rights, and to some degree, Rebecca, you addressed the issue of personal responsibility, but if you could just take a minute to respond to that issue of, do we have a responsibility to stay healthy? And does that affect how much health care we have a right then, or that we deserve? So if you could each perhaps give a quick response.
Want me to go first? Go ahead.
Sure.
Is this on? Can you hear? I think we do have a responsibility for our own health care, not health care, but we have a responsibility to live well and to live in a healthy fashion. However, after when I said those 4 things that are the biggest source of costs of health care, they included things like accidents and injuries. People need health care for all sorts of reasons. They go skiing and they have an accident. They're in a car wreck. They go hiking and they trip and fall down the side of a hill. Are we going to say that we shouldn't provide health care for them, that they shouldn't have done those things? I think it's too much a slippery slope. I think we're human beings. We all deserve health care.
let me see if I understand the question correctly. You were asking about the role of personal responsibility in healthcare?
In our health.
In our health. Well, you know, obviously, we owe a debt to ourselves. I mean, every person here owes a debt of personal responsibility to themselves to keep themselves as healthy as they can, and to the people around them, their spouses, their children, etc. As far as I'm concerned, that has absolutely no bearing on the question of whether health care should be universal, should be provided by the government. You simply cannot go around judging whether someone was personally responsible for lung cancer because they didn't get out of a casino where smoking was allowed, I mean, or they smoked themselves. That should have no bearing on the delivering of health care. Personal responsibility extends not only to yourself, however, it extends, and I think as Mary pointed out so correctly, to the entire society. As human beings, we are responsible to and for other human beings, not because of laws, but because we are human beings, and because we are, the only way that a society can function over the long term is on an ethical and, if you wish to put it that way, moral basis. However, I do take strong exception to the belief that social responsibility can only be enforced through governmental action. Social responsibility, as I tried to make clear in my presentation here tonight, is best exercised through voluntary association by the vast majority of human beings who do care for their fellow human beings. The fact that you don't wish, let's say healthcare, obviously, to be run by and for the government, it doesn't mean that you have no sense of social responsibility and common good. It means that you prefer to exercise that social responsibility as an individual caring human being through voluntary association. This has worked all throughout American history. It is working today. It can work in the future.
Rebecca. And I too would say I believe that there is individual responsibility for your health, but it is your choice to make those decisions. I think tobacco, alcohol, illicit drugs, people make a choice in continuing those habits, but they're very, very addictive. And it's no different than if I say to you, don't run out into the traffic. If you run out in the traffic and get hit by a car, we're still going to treat you. So you need to make an individual choice about what you want for your own health, but if your health fails, you do deserve to get health care.
And, you know, related to that is this issue of prevention and the investment in health as a society. And many of you touched on this issue of what is the benefit to us as a community to invest in health? And do we do that? You know, you've presented different ways to do that, some which are universal health, some which would be investing through personal action and personal investment. But if you could talk a little bit about what is that investment in health through preventive medicine that we ought to be thinking about as we make these decisions.
For one, I'd like to see free immunizations for every single child in the country. I'd like to see adults also have access to immunization. I called Safeway the other day and said to them, their pharmacy, how much does it cost for a DPAP? That's the immunization you need to prevent pertussis, whooping cough. We've had a bit of a flare-up of that in our peninsula. And it's a very dangerous condition. People die from it. One shouldn't, you know, if you're very poor, it's hard to pay for things like that. So I think that kind of prevention should be automatic. I think every pregnant woman in the United States should have preventive care. We could go on, a whole bunch of things. And I'll just say one more thing. The best way to get towards good prevention, I believe, is to give everybody access to health care. If you never get to see a doctor because you don't have one, you're not going to hear much about what you should or shouldn't be doing.
No, I can't believe that any reasonable human being would deny that prevention, particularly in healthcare, an ounce of which is worth a pound of cure. Prevention is obviously far more desirable than trying to cure something after it's happened. So no disagreement there. The only question that we're asking is, who provides the prevention? And where is the responsibility? Are we going to take any social responsibility for ourselves at all? Or are we simply going to hand it over to the government and say, take care of me, prevent me, and cure me when I don't get prevented? I, for instance, would not want someone from the government telling me that chocolate brownies are bad for me and way too many of them, I'm not going to get health care. I happen to be a chocolate brownie addict, and I very much resent this interference of the government on my part. However, I am willing to accept the fact that chocolate brownies are not good for me, and to try my hardest, and this is a come see, come saw situation, not to eat so many that I balloon up to the point where the inevitable happens. So, prevention, of course. The question we're talking about tonight is, where does it come from? Who funds it? Who administers it?
Absolutely, prevention's extremely important. It's much cheaper to prevent disease than to treat it after it happens. But I would also plead that we take the prevention and move it more and more into our schools and really focus on our children. Exercise, healthy lifestyles, education about non-smoking, because starting in childhood will help to combat the epidemic of obesity that we have. I cringe when I hear that there's schools in the country that are cutting more and more resource, or cutting after-school sports projects, or making children that don't have the money to buy their equipment pay for their own equipment. So prevention really does need to start in childhood.
You know, and to follow that up, so you brought up the issue of really broadening our thoughts about health and health care beyond just the hospital, the clinic office, but to our schools, to really thinking about health more globally. And one of the issues that I was wondering about, and perhaps you all would, or some of you would like to respond to, is this really gets at the health care as a commodity versus a right. If we view it as a commodity, and we view it as a right that is a negative right, then we don't have the same kind of investment in healthcare and in the prevention. So when people switch between healthcare plans, there's not as much motivation for a healthcare plan that's going to have you for 2 years to invest in your health in 20. And investing in children's obesity is a long-term investment. So could you all talk about that? I mean, creating, for instance, catastrophic insurance, people are typically not on for very long. So very slow interest in doing preventative. To really move towards preventative and public health, we need to have long-range views. Would you like to respond to that?
I'll be happy to. I actually graduated from medical school in an era of, in the last, managed care was really big. And one of the things that we talked a lot about at that time was really focusing on the health of populations. We knew as healthcare providers that to be successful, we really did have to focus on prevention, healthcare screening, not only the health of our children, but making sure that women were getting their pap smears and men and women were getting their colonoscopies and really catching things early. So we were really paying a lot of dollars up front, really looking at the healthcare savings that would happen in 10 or 20 years. Well, we all know what happened to the managed care pendulum. Hear about, I hate to age myself, but I think it's been over 20 years ago. Well, now I see the pendulum swinging back. So I really do think as a country, we really do have to look at the benefit that's going to come for us in 20, 30, 40 years.
I think I want to jump back just a little bit because you talked about healthcare as a commodity, and that's a point that Phyllis and I have a little difference on here. I wanted to say there were a couple things about why I don't think healthcare can be thought of as a commodity. One, in market theory, the idea is that all of us are free agents in a marketplace. So I want to buy I'll make this up, I want to buy a flat screen TV, or I want to buy a new Honda. Well, the idea in the market is that we're free agents. We can go shop at different places, and we can look at consumer reports and do whatever we want to do to figure out which TV, which car we want. But that doesn't apply to healthcare. We are not free agents. We do not have access to the information that's available in a pulmonologist's mind and their skill and training to tell us specifically what we need. So we're not free agents in healthcare. I just wanted to say that. Thank you. Phyllis, would you like to comment?
Well, I take exception to that. This will probably not come as a surprise to anyone in the audience, but I recently had an operation myself, and as a free agent, trying to determine which of the doctors I wanted to perform the operation, I went on the internet and I did a great deal of research as to the records of these physicians, how many operations they had done, what kind of success rate they had, what kind of care the hospital provided, and so on and so forth. I was very much a free agent, and I selected a doctor who, as a matter of fact, performed magnificently for me, and I'm living a much better life for it. For my part, doctors and nurses are God's angels on earth. I wouldn't be sitting here alive and kicking and belligerent in front of you had it not been for the incredible care that I have received from dedicated physicians and nurses like the two we have here today, and Mary as well, of course. But you are a free agent in many cases. You have a great deal of choice in choosing your doctor, your hospital, the kind of care you want, the type of operation you're going to get. The question isn't whether you can make an informed choice about your medical care. The real question comes down to, can you afford it? Affordability is the rock on which medical care is foundering in this country. And the question before us is, how do we deliver not just adequate health care, but superior health care to the people who need it in an efficient manner which we can afford? Mary is confident that we could afford universal health care. Perhaps she is right. From the studies I have made of universal health care in other countries, they afford it, but at quite a cost. I mean, there are, those of you who are familiar with economics in the audience know that economists speak of what we call opportunity costs. Every choice that you make in life has an opportunity cost because you have chosen this and not this. In healthcare in particular, the opportunity costs are stunning. If you go to England, for instance, the average wait for what is determined to be elective surgery by a board of government-appointed people is 28 months. Now, in the case of the rotator cuff that Mary talked about, perhaps that's a fine way to wait for a rotator cuff, which isn't life-threatening. But things such as, for instance, defective heart valve replacement have been determined to be elective surgery in England. Okay? I, for one, would not like to be the parent of a 10-year-old child who had to wait for 28 months to get a defective heart valve replaced. Okay? We live on the Olympic Peninsula, and most of you are familiar with the fact that there are a number of Canadians who come here to get health care that they can't get in Canada. This doesn't mean that the Canadian system is wrong. It just means that the opportunity costs of government-delivered and rationed universal health care are withholding for quite some period of time of critical health care. and the withholding of critical health care from people who are deemed too old, too far gone in sickness, to be worthy of having that rationed health care delivered to them. If you've taken a look at what's going on in the Netherlands lately, it's positively scary. In the Netherlands, they now have positive euthanasia. That means it is left to the doctor to decide whether a person who is too old or too sick should be denied health care and given only comfort care, if that. That's a scary thought for me. That's an opportunity cost that the Dutch people have decided is worth it. And I think in America we better take a good long look at our opportunity costs before we decide to hand over our health care to the government.
Please, comments. Couldn't you just see it?
Phyllis, you keep combining the two. There's two issues here about universal health care. One is who is the payor? Who pays the hospitals, the physicians, the physical therapists? Many, many countries have a single health care payor. But who delivers the care is private. That's the way it is in Canada. So it doesn't have to be government-delivered health care. We do have a government-paid and delivered health care system in the United States. That's the VA. We have a government payor with private deliverers in Medicare. Most of the countries have a single payer and that everybody contributes into, and then the delivery is private.
Well put.
Thank you.
Okay, before you leave, a couple of things. First, very grateful thanks to Dr. Sarah Shannon and to our speakers. This was a very complex forum, and you did very well. You served our purpose, and we appreciate it. A couple of things. I want to do a couple of thank yous. We want to thank Vicki DeMott, who is our technical genius on loan from OMC, who helps us with the audio visuals. We want to thank James Trikas, who is the video recorder of our session has been recorded because we hope to bring these out to the community, to interested groups, to just see the discussion and to start the dialogue. I want to thank our timers. Good job. I want to acknowledge the committee. Sarah Johnson is our chair. Tommy Schwent, Sharon Lee, Mary Wegman, Susan Boland, Doris Rehern, and Jennifer Taylor. Thank you. We've all worked pretty hard on this. Mostly, we want to thank you for coming.